Hello, welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist, trained at Duke University, been practicing in South Florida for a little over 20 years. I'm the medical director here at Broward facility, and I chair the antibiotic stewardship, and I also chair infection control here. We have internal medicine residents, and Amol Preet was rotating with me, and she's wonderful, and she has an interest in infectious disease, and she's going to be presenting today. We also have a fellowship program and a PD for that. And we are joined by Dr. Zayzoun Amir, and he's also, let me introduce you to him. Amir?
Hi, good evening. My name is Amir Zayzoun. I'm the Infectious Disease Fellow at Broward Health North. I'm happy here to join Dr. Gopal, her presentation. Actually, infectious disease, the main reason we were talking, Dr. Gopal was asking me what's the interest about why I choose infectious disease fellowship, because very interesting specialty. Especially with the previous experience as a hospitalist, internist, internal medicine, infectious disease, it's where you go deep in the diagnosis of the diseases, especially the infectious diseases and the treatment. So it's a very interesting field. Every day there's interesting cases we see in this specialty. And every day, like even if every day we learn something new, there is not enough in this specialty.
Okay, great. So let me introduce you the who is going to present today, Amol Preet, and she's going to be talking about amoebic liver abscess and in general a little bit about liver abscess. So you can talk.
Okay. Hi guys, this is Amol. I'm originally from India. I recently joined my residency at Broward Health North, and I'm the first year internal medicine resident in the categorical program. I am really excited to be presenting on the topic of amoebic liver abscesses today. I love my rotation with Dr. Gopal. I feel that I've learned a lot, and I wanna grab much more experience and dig deeper into the specialty because I have an interest to pursue this during my fellowship. So now we're gonna start sharing, discussing our topic, which is liver abscesses, and we're gonna focus more on the amoebic liver abscess.
Yes, we can see your screen.
Okay. So we're gonna discuss briefly about Entamoeba histolytica. When do we suspect it, and the other hepatic abscesses as a differential. Okay, so when do we suspect amoebic liver abscess? So first of all, I want to emphasize that whenever a patient comes to you with right upper quadrant pain, fever, and recent history of travel, then you should be thinking about something tropical, and that includes the amoebic abscesses. So always look for the history of travel. We don't want to miss it. So the patient would say that the history is subacute with 1 to 3 weeks. He's been having like low-grade fever, right upper quadrant pain, and you do the ultrasound, you see some hypodense lesions on the liver, and you see that the blood cultures are negative. So you don't know what's going on. So we'll think if it's bacterial, it should show up on the cultures, but the cultures are negative because it's something else. So we have to keep a high index of suspicion in such cases. And in the CT, you can also do a CT. There will be solitary abscess in the right lobe, and it responds to metronidazole, as simple as that. But if you miss it, then you're gonna like keep figuring out what's going on with the patient. Okay. So our objective of this presentation would be to review briefly the epidemiology of Entamoeba histolytica, differentiate various types of hepatic abscesses, and discuss various diagnostic approaches, and outline briefly the management strategies. So what is Entamoeba? So amoebiasis, it occurs worldwide, but it is more prevalent in the lower income countries because of the poor socioeconomic conditions and the lower like sanitation levels over there. So it's more endemic in the Asia, Africa, Latin America. We don't see it that often in America, but if the patient has traveled outside of the US, then they can acquire this. And the transmission is usually fecal-oral. The pathogenic organism is the Entamoeba, and we see around, 50 million cases annually worldwide. So this is something to be something to think about whenever you get any patient with right upper quadrant pain, fever. So this is a very nice life cycle of Entamoeba, that how you get infected and how it causes the disease in the patient. So whenever an infected patient passes the cyst and trophozoites in the stool of the Entamoeba, then the other person can ingest those cysts from the fecal-oral route due to the poor sanitation conditions, and these cysts go into the intestine. So in the intestine, it is a non-invasive colonization initially, so we call it as the intestinal amoebiasis. But when it invades the mucosa of the intestine, it goes into the large intestine, then it can go into the portal circulation and move to the liver, to the lungs, and to the brain. Then that's where we call it as the extraintestinal disease, where we will see the more severe manifestations of the disease. So the thing to consider about is the cyst is the infected form. The infective, then it goes to the intestine, and when it invades the mucosa, then it can go into the organs, and most commonly affected organ is the liver, lungs, and the brain. So it shows the same thing. So we'll go forward. So pathophysiology of the liver abscess, trophozoites. So when you ingest the cyst through the fecal-oral route, trophozoites initially they are in the intestine, but when they invade the intestinal mucosa, they can go into the liver and they form like an anchovy paste. And the anchovy paste, it is formed in an abscess. So it is usually in the right hepatic lobe. So the most clinical features you will see is diarrhea. Whenever the patient is in the intestinal stage, you will get diarrhea, you can get dysentery, low-grade fever, subacute onset from 1 to 3 weeks. But when it invades the mucosa, then that's where you get like bloody stools, dysentery, fever can worsen, and if it invades the liver, you'll get the right abdominal pain. It can cause altered mental status if it goes to the brain. So all of these complications can occur if it invades into the bloodstream. So for extraintestinal amoebiasis, yeah, like we discussed, fever, right upper quadrant pain, absence of jaundice in most cases because it doesn't involve the biliary tree. It goes from the portal circulation and lodges into the right hepatic lobe. So it forms like a solitary abscess with anchovy sauce in it, and it causes like the right upper quadrant pain, dysentery, and the most commonly affected are the young men. So when now you have suspected that it could be Entamoeba, histolytica, amoebiasis. So how do we diagnose it? So first of all is the imaging, and you see hypodense lesions. So on the CT, you can see like hypoattenuated, solitary, subcapsular lesion, like just lying below the liver capsule. You have to differentiate it from the pyogenic, because in pyogenic you see multiple lesions, but in amoebic liver abscess you will see like a solitary big lesion. In the labs, you can see transaminitis, elevated liver enzymes. Culture is often negative. It's positive in the pyogenic, but it's negative in the amoebic liver abscess. In the serology, so the most important diagnostic test is anti-amoebic antibodies. You have to test for the Entamoeba antibodies, which is positive in serology, and stool, ova, and parasite are negative. So this is how the Entamoeba histolytica trophozoite appears on the microscopy. So it has the ingested erythrocytes, and this is a trichrome stain. So this is how the ulcers appear on the intestine. So this is a cut section of the intestine. When it invades the mucosa, the trophozoites would form a flask-shaped ulcers, and you can see it very nicely in the pathology specimen in the slide. So this is how it appears on the imaging. So you will see a hypodense lesion in the CT. It's walled off like an abscess and having the anchovy sauce in it. So that appears darker, and the rest of the liver parenchyma appears brighter than the lesion. So we would call it like hypodense. So the differential diagnosis would be, now we found a hypodense lesion. We think it's abscess, but do we know it's amoebic or it's pyogenic or it's fungal? So we have to rule out like what's causing this infection. And this is where we go through our differential diagnosis. It could be pyogenic abscess. It could be a hydatid cyst. It could be a malignancy. So to rule those out, we have to discuss further about it. So I would like Dr. Gopal to share her views more about the pyogenic liver abscess.
Yeah, so so far, I mean, it is excellent. You covered most of the points for the amoebic. So the pyogenic liver abscess, there is something that everybody should be aware about is a Klebsiella strain can cause a pyogenic liver abscess. It is a hypervirulent Klebsiella pneumonia strain. So it was first described in 1980s in Taiwan, and subsequently many has been reported in Southeast Asia, Europe, and North America, all those places. Basically, this is a very virulent strain of Klebsiella and very invasive syndrome. And classically, you will have, like, as you mentioned, many of the bacterial liver abscess can be not just monomicrobial, it can be polymicrobial infection. But with this Klebsiella strain, it can be just that bacteria alone. And the key aspect to know about it is it can cause metastasis. It can cause endogenous endophthalmitis. It can go to it can go to the brain and cause meningitis. We have seen brain abscess with that. And you can get septic emboli. Patients can get septic arthritis, osteomyelitis, and even prostate abscess, soft tissue abscess. So this is a very, very different entity that everybody has, you have to be aware about. The other aspect about this kind of syndrome is usually it is seen in healthy patients. And diabetes is one risk factor. Usually it is present in up to about 60% of patients, but these are seen in immunocompetent host. So that is another distinctive feature. So there are different serotypes. You don't need to know about it, but there are K1, K2. Those are the predominant strain, and there are many, many different strains in that. The other aspect to it is this causes mucoid colonies. So if you go to the microbiology lab and there is a specific test to detect this strain, it's called string test, because these are, you lift the colony and there will be a loop, because it's so viscous, and that is why it is called string test. And how do we get this type of liver abscess? It can be just sometimes patients may be colonized, and so it can be just a translocation from the gut. People can get this. Otherwise, it can be from the blood. You can get seeding of this, and it can be hematogenous spread. And treatment is the same as bacterial. You have to cover for bacterial coverage. You can do third generation cephalosporin, ceftriaxone. And I usually treat a combination in liver abscess, always add in metronidazole for anaerobic coverage. There is an entity that you have to be remembering, these hypervirulent strains. Sometimes there can be ESBL producing strains also. So if that is the case, then you have to use carbapenem and meropenem. And then treatment is, percutaneous drainage. Definitely, if you are suspecting hypervirulent strain of Klebsiella, you need to get an ophthalmology evaluation if the patient is having any visual symptoms. In terms of the prognosis, is usually pretty good if you have a prompt early diagnosis. But if you delay the diagnosis, it can cause vision loss, even death. Otherwise, neurological complications can happen. So that is something that everybody should know, which I thought it's very relevant since we are talking about liver abscess. So you can continue.
Thank you so much, Dr. Gopal, for explaining it so nicely. So, as we discussed, amoebic liver abscess is more common in usually younger adults. Men are more commonly affected, and these individuals are usually not diseased. So, any like healthy patients could get it, like healthy person can get it. So that's one of the differentiating features. And pyogenic is more common in diabetics and with prior history of gallstones. But in amoebic liver abscess, you have to figure out if the patient has traveled to the endemic areas. So this is a slide comparing the amoebic, pyogenic, and fungal abscesses. So the common age, as we discussed in amoebic liver abscess, would be 20 to 50 years, which is like the young individual. In pyogenic, those are like diabetics and elderly individuals. They are more susceptible to get these. And in fungal abscesses, you think of fungal infections mostly in the immunocompromised patients. The onset would be subacute in amoebic liver abscess with a history of 1 to 3 weeks of onset, low-grade fevers. In pyogenic, they would be very septic. So sick patients, very septic, acute onset, think of pyogenic. And if they are like having a cancer patient, if they have any immunocompromised state, think of fungal. So right upper quadrant pain would be seen in all of these. The labs would show mild transaminitis, but leukocytosis is usually not severely seen in amoebic. It can be mostly seen in pyogenic, and in fungal, you would see neutropenia. So that's the differentiating features in your CMPs in your labs. In the imaging, the amoebic liver abscess is solitary, but the pyogenic and fungal are multiple. So that differentiates it from them. And in the treatment, you give metronidazole, paromomycin, and do not drain the amoebic liver abscess unless it's indicated. But in pyogenic, you give antibiotics depending upon the organism in the blood culture, and then you can also do the drainage. Similar is with antifungals. You give for fungal abscess, you give antifungals and you do the drainage. So the diagnostic tools are this we already discussed. Imaging, in the imaging, ultrasound is the first line. Then you can do CT, MRI to delineate the abscess. Serology, we do anti-amoebic antibody assay by ELISA. In the stool studies, you can see trophozoites, but not usually. The stool ovine parasite would be negative because they are the cyst. That usually can be missed in the normal stain, and you have to use the trichrome stain to see the trophozoites. And you really do aspiration for amoebic abscess, and blood cultures are usually negative in amoebic, but they can be positive in pyogenic liver abscess. So for management, the most important drug is the metronidazole. As Dr. Gopal said, whenever you get an abscess, think of like adding a metronidazole if the patient is not responding to the empiric treatment. So start with the metronidazole 500 to 750 milligrams 3 times a day for 7 to 10 days, or you can use tinidazole, which is 2 grams daily, reduced dosage for 5 days, and always use luminal agents to clear the intestinal trophozoites and cysts. You can use paromomycin or diloxanide furoate. And aspiration, we don't need to do aspiration unless it's severely indicated. We will discuss the indications for aspiration in amoebic liver abscess. So for pregnancy, favor treatment with petronidazole, but the use is controversial. So some literature says you should prefer chloroquine because it's safe in pregnancy. So you can use chloroquine 600 milligrams for 2 days, followed by 300 milligrams for 3 weeks, followed by the luminal agent, which is paromomycin. So when do we drain the amoebic liver abscess? If the cyst is more than 10 centimeter in diameter, if you think it's gonna rupture, like it's near the pericardium, you think it can rupture into the pericardial cavity, then you have to drain it. Or if the patient is not improving with the empiric therapy. So now you drain the abscess and you put a pigtail in it. Now, what do we do now? So when do we remove the pigtail is if the size of the residual abscess on the follow-up ultrasound, it has decreased to less than 3 centimeters, or if the patient has improved clinically, he doesn't have the abdominal pain, he doesn't have the fever for 48 hours, and the drain is showing less than 10 milliliters per day for 2 consecutive days. And there's improvement in the leukocyte count. That is when you pull the pigtail out and you can send the patient home. So for management, the takeaway message is use metronidazole as the drug of choice. Follow it with a luminal agent always to eliminate the intraluminal cyst, which is the paromomycin and iodocanol. Aspiration only if diagnostic uncertainty, there's a rupture risk or poor response to the empiric therapy, and avoid routine drainage in amoebic liver abscess. But for pyogenic liver abscess, Dr. Gopal has already explained about it. Always use gram-negative coverage with IV antibiotics. If it's ESBL, consider PENEMS. Percutaneous drainage is the standard of care. So always you can do the surgical drainage if multiloculated or failed percutaneous therapy, and treat the underlying source. Complications can occur if the size of the abscess is too big. It can rupture into the pleural or peritoneal or the pericardial space. It can cause empyema or peritonitis. It can cause septicemia, or it can cause like a chronic abscess with a walled-off cavity. So clinical pearls, think of amoebic liver abscess in any immigrant, or ask the history always about the travel history in any patient suspected of any infectious process going on, because you can get these infections in the endemic regions. So do not rush to aspirate. If amoebic liver abscess is suspected, do your serology, find out the ELISA positive, then think of treating it with metronidazole, paromomycin. Then if it doesn't improve, then think of the other differential diagnosis. So we're gonna discuss briefly a few case vignettes. So first is a 35-year-old male immigrant from India. He has fever, right upper quadrant pain, weight loss, history of dysentery, some bloody diarrhea, labs show elevated leukocytes, mild transaminitis. Serology is Entamoeba histolytica IgG positive, and ultrasound shows a solitary hypoechoic lesion in the right lobe of the liver, which is 6 centimeter. And CT shows well-defined low attenuation lesion with the peripheral enhancement. So what's the diagnosis and how do we manage it? So I think we've discussed about it. It's amoebic liver abscess, you treat it with metronidazole 750 milligram 3 times a day for 10 days, followed by pyromomycin. And percutaneous drainage is not required in this case because it's like a 6 centimeter. Okay. Second case scenario is a 60-year-old male with history of diabetes. So this is the catch point over here, history of diabetes and cholelithiasis. And he presents with fever, chills, right upper quadrant pain, and jaundice. You do the labs, you see elevated white count, elevated liver enzymes, and cultures are positive here. Cultures show E. coli, and imaging shows multiple small abscesses. So this is another catch point, multiple small abscesses in both the liver lobes. So what's your diagnosis? It's pyogenic liver abscess. You do the cultures, look for the culture sensitivity, but in the meantime, start broad spectrum antibiotics with ceftriaxone and metronidazole. Percutaneous drainage is required only if it is more than 5 centimeter or multiloculated. Next case scenario is a patient post chemotherapy for leukemia, 45-year-old female, presents with fever, right upper quadrant pain, hypotension. Labs show neutropenia. So neutropenia is always a suspicion for fungal infections. You see elevated CRP, cultures show candida, and imaging shows multiple hypodense lesions with gas in it. So how do we treat it? We give antifungals, and for candida, we give echinocandin, and drainage only if it's refractory to the medical therapy. So takeaway points. Pyogenic abscesses are more common in the US, but amoebic abscesses are critical to identify in high-risk patients, which would be the immigrants and those with a history of travel. So travel and epidemiology are your best diagnostic clues. Imaging overlaps between all these three, but serology and response to treatment help us to differentiate between these clinical conditions and treat amoebic abscesses medically, and always reserve the aspiration for selected cases. All right, thank you guys.
Thank you.
Okay, so it was excellent presentation, and hope you learned a lot with that. Once you know, the teacher is the best learner, and so I'm hoping that you will be able to diagnose and treat all the liver abscesses that you will see. Definitely, you will see that in clinical practice. And so, good job and excellent presentation.
Thank you.